Okay, welcome everybody to the Long COVID workshop. My name is Munir Mohammed. I'm chair of the UK Pharmacogenetics Stratified Medicine Network. This is a network which has been running for over 10 years. And what we do is partner with organizations. And today we've partnered with ABPI to be able to run a workshop looking at what the current situation is and trying to develop a roadmap in terms of where we need to go for the future. So thank you very much for ABPI for partnering with the UK Pharmacogenetics Stratified Medicine Network for this particular workshop. We've got a fantastic lineup of speakers today. Obviously, we are still going through a pandemic. It has disrupted everybody's lives in one way or another. And what we are, as we are coming out of it, hopefully over the next 6 months or so, we are going to be left with people suffering with the long COVID. Obviously, there's been a lot of publicity about what long COVID is. There's quite a lot of confusion about what long COVID is, and there's so many manifestations in terms of what people suffer. So I think this workshop gives us an opportunity to really look at what is the latest in long COVID and where we need to go, particularly in terms of thinking about future treatment, future management, future clinical pathways, stratification of disease, so that we can actually tackle this problem, which is going to be with us for many, many years. And it is important that we tackle it at scale. So I'm very grateful for all the speakers who've agreed to come to give talks today. The way we work this is that there are talks in the morning. At the end of every talk, there's a chance to ask questions live. And if you do want to ask a question, then please use the raise hand function on Zoom. I'm sure you're all used to Zoom now. We've all been working with Zoom for the last 18 months and so on. So please use the raise hand function and I'll come to you to ask a question. If we don't have enough time for the questions, then there is a chat function as well. So please put the sort of question in the chat function and the speaker hopefully can answer directly on the chat function as well. So the idea is that we have these talks, we'll have breaks in between, so you can get a bit of a rest. We'll have a lunch break, and after that, one more talk. And then after that, what we do is tend to break up into some focus groups where they will have a chair and rapporteur, and there are specific questions which are being posed for each particular breakout group. And the breakout groups will then come back and report to the whole workshop in terms of what their findings were. Okay, so that's the plan for today in terms of moving forward. So I think I'm just going to go straight on to the first speaker. Great to hear from Professor Janet Lord, and she's going to be talking about what is long COVID. Janet is Professor of Immune Cell Biology, University of Birmingham, and lead for the Birmingham BRC's theme on inflammatory sarcopenia. She works in many different areas, particularly healthy aging, but also been looking at the long-term effects of COVID through the COVID study. So Janet, look forward to hearing from you.
Okay, so thank you for the introduction, and I've been given the task of trying to go through exactly what long COVID is, so hopefully I will achieve that. First of all, I think just looking at where we are now with COVID-19, this disease caused by the SARS-CoV-2 virus. So worldwide, we're looking at approximately 219 million cases and 4.55 million deaths. In the UK, we've had approximately 7.4 million cases and about 135,000 deaths. So really, you can see from the map there, really a classic pandemic. As far as hospitalization goes, you can see here on the graph, we've got wave 1 there for hospitalizations, a much more severe wave 2, but with approximately 500,000 hospitalizations in the UK. But what do our patients look like? If we look at age and sex differences for those who've succumbed to the infection, and these are data from last year, but the picture hasn't really changed very much. You can see a very clear age effect here, and approximately, well over 90% of the cases are in the over 65-year-olds, so a real age-related infection. And what about severity? Again, the same sort of picture. So on here, we've got those requiring a lower level of care in hospital, and again, very much age related. And when you go to those who end up in critical care, again, you actually see a male dominance here, and there's sort of a bulge really in the early old age stages. Again, largely because the very old are unlikely to be admitted to critical care anyway. If we look broader than that, this is from the paper from the back end of 2020 about the sort of predictors for mortality. Again, this is for data from 17 million adults covering almost 11,000 COVID-related deaths. And you can see here a real age-related effect there coming out in the hazard ratio with, well over 10-fold risk for those over 70-year-old. Male dominance again coming clearly in these data. Being obese again a real increased risk the more obese you are. If we go down here to ethnicity, again this predominance of the different ethnic groupings again showed very clearly in this data. But also the deprivation scale, I think you can see here very marked from the least deprived to the most deprived at the bottom there, a real increased risk there of death from COVID-19. And the last factor to come in really, the presence of comorbidities. So here for diabetes and also chronic respiratory disease, both of those increasing your risk of dying from COVID-19. And of course, you'll all heard that during the pandemic and ongoing now, real efforts through this recovery platform trial to find treatments. And in fact, this was preceded by a trial called Catalyst, which did very quick trials to try to find hints of drugs that might help. But you'll all be aware that dexamethasone came out very early on as something that could reduce mortality with COVID-19, and this is now standard of care with other therapies coming down the line as well. But really what I've been asked to talk about is, of course, the focus of this workshop, which is long COVID. And what we've got here are the definitions released by NICE, so we can consider acute COVID-19. These are signs and symptoms of the disease for up to 4 weeks, so often the patient would still be hospitalized here. Then in the 4 to 12 week period, this would be called ongoing symptomatic COVID-19. But what we define as long COVID, the post-COVID-19 syndrome, is really when the signs and symptoms develop or persist for 12 weeks or more, and that these symptoms are not explained by an alternative diagnosis. So it's this 12 weeks and beyond that I'll be really talking about for the rest of the talk. And what I'm going to go through first, and actually most of the talk, is going to be about this study FOSP-COVID, which is led by Chris Breitling from the University of Leicester. It's the post-hospitalization COVID-19 study. So looking at those patients who were sick enough to be hospitalized. And it's a national consortium. It really is across the nation with many, many sites involved, trying to understand what underlies COVID-19 to therefore try and develop and improve health outcomes for our patients. And we're looking now at over 300,000 post-hospitalization survivors of COVID-19 in the UK. So this is a large population base to be aiming to study. And there are three main aims of the study. We want to try and understand the mechanisms driving the consequences of COVID-19 post-hospitalization. Why are some people recovering more quickly than others? Why do some people develop new health problems following their infection? Also looking at the impact of interventions, so which treatments in hospital might have been helpful as far as recovery from COVID was concerned, and how can we improve care once the patients are discharged. And lastly, it's really developing a platform for in-depth studies. So recruiting these patients is developing a structure that will allow researchers to join in the research, pose their questions, and really lead to future research on COVID-19. And so with this such a large study, there are many working groups and charities and PPI involved in COVID. And you can see on the left here, it's very much a person-centered approach, but really is looking at all aspects of health in the COVID-19 survivors. We're considering their mental health, their physical function, the social support they're receiving, and their lifestyle. And then around this outer circle, you can see some of the aspects that we're considering, sort of renal, cardiac, respiratory, some of the metabolic aspects of the patients, their muscle, bone, sleep, cognition. So really, there's very little we're actually not covering. And how we're tackling this is really bringing in experts from each of the areas. So we've got Professor Gisley Jenkins running the lung fibrosis team. I'm involved in the rehabilitation, sarcopenia and fatigue team. And we've also got a link in immunology with a separate consortium called the UK Coronavirus Immunology Consortium. So a consortium of immunologists around the UK to tackle that element. And the platforms are involved to give you some of the flavors of what is going on. So there's an imaging platform. So this is led by Betty Rahman down at Oxford, and they're using MRI and CT really in the patients to look at different organ systems. There's another one I'm going to tell you about later, Dynamo, led out of Nottingham. There's various omics, so all of the various samples that we're collecting will have proteomic analysis, transcriptomic, metabolomic, so really in-depth omic data for analysis. The samples we're collecting are stored and will therefore be a bioresource for the future. So that I think will be also valuable going forward. Then the whole of this data, the clinical data, the research data are pulled together in a vast data hub that again can be accessed by researchers who can pose their research question and then apply for access to these data. In all of this, we've got PPI representation. You'll see from the demographic data I showed you that it's important that our research really is supported by the patients and that we really cover the populations that are affected. So we've got good minority ethnic representation in our PPI groupings. We also have social scientists involved, considering some of the broader aspects of recovery from COVID-19, as well as health economists looking at that aspect as well. So it really is a very, very broad consortium. So what's the study design? So in the first, we have what we call tier 1. So we're recruiting we're collecting just the clinical data on 7,000 hospitalized individuals who agree to join the study. We then have tier 2, where this is an extended data platform for 3,000 individuals. And these come in and they spend almost a day with the researchers. We look at their mental health, their fatigue, physical performance, things like the physical performance battery, timed up and go, that sort of thing. Ongoing pain, we assess frailty, then various measures of cognitive function, lung function, kidney function, and then a range of blood markers such as inflammation, HbA1c and NT-BMP. So really, really broad measure in this tier 2. And then there's tier 3. So tier 3 is where we can recall patients for looking at a particular characteristic. So for example, if the researchers are interested in fibrosis, then the patients would come back and have a much more in-depth analysis of fibrosis. And I will tell you in a little while about the sarcopenia and frailty subgroup. So they come into tier 3. So this is where we can collect further samples and specific data. The patients essentially have 2 visits. The first visit, they're coming anywhere between 2 and 7.5 months of being discharged. So this is their first visit. And then the second visit is 12 months after discharge. And this is the phase we're in now for the majority of our patients, where we're now at the 12-month stage. And so we've just published our first paper, which is on the first 1,000 patients. It's actually on 1,077 participants. So what do they look like? Well, first of all, their mean age was 58, so actually really quite young. 36% are female. The ethnicity is really quite spread there. You will see predominance of white, but also a good representation of South Asian, Black and mixed ethnicities. A large number, you'll see, again, not surprising from that age, 68% were still working before they had their COVID. Over half were categorized as obese, so really a dominance of being overweight or obese in these patients. Over half of them had 2 or more existing health conditions, so be classed as multimorbid. And of those conditions, the dominant ones were heart disease at 40%, lung disease at 26%, and diabetes at 20%. So this is what our participants are looking like. What about their acute therapy? So when we look at the spread of the severity of their acute illness, 21% would be considered mild, so they were required no continuous supplemental oxygen. Approximately a third required oxygen only, 17% non-invasive respiratory support, and almost a quarter did require being in ITU and invasive mechanical ventilation. Of the treatments, in our first 1,000, approximately a third have been prescribed steroids, so dexamethasone, 81% received antibiotics, and 32% therapeutic anticoagulation. What about the recovery? So actually in our grouping, only 29% felt fully recovered, so really quite a low level, so just over 70% still bearing some symptoms of the disease. And the median number of symptoms was 9, but a broad range there from 4 to 16. 18% were no longer working, so of the original 68% that were working before the disease, 18% no longer working. 19% had experienced a health-related change in their occupation, so they were working but had to change their job role due to the infection and the COVID-19. And a fifth had developed a new disability, so many of them really quite unwell at the 5-month stage. So what sort of factors were associated with patient recovery? Well, you see at the top here, age, and it's actually middle age. So the reference here on the plot is 50 to 59, and pretty well anybody over that was more likely to recover. So being middle-aged really was an indicator of poor patient recovery. Females are more likely to have a poor chance of recovery. Having 2 or more comorbidities, so being multimorbid, again, less likely to recover, and having experienced WHO 7 to 9 categorization, so mechanical ventilation also associated with a poor chance of recovery. Interestingly, the steroid admission during the hospital stay didn't affect chances of recovery, so neither good nor bad. And interestingly, when you look at the patients and look at some of their symptoms, and we really look at a very broad range of symptoms. So some of the questionnaires here ask about breathlessness, fatigue, anxiety, depression, PTSD. We assess them for cognitive as well as physical performance measures. And there's clearly 4 clusters here. They've got one here, a very mild cluster that really has a little bit of brain fog, but nothing much else than that. Another one here that really hasn't got any fatigue or mental health conditions, but does have cognitive impairment. A group here that is more severe on the physical fatigue and the anxiety depression side, but doesn't have the cognitive decline. And then another one here, very severe symptoms. And again, this is again shown here with the cognitive impairment and the various symptoms here, with the cluster 1 very severe, cluster 2 severe for mental and physical, cluster 3 moderate with this brain fog, the cognitive impairment being very dominant here, and then the mild group. And what do these clusters look like when we break them down further? So the 2 severe categories are female dominated. They also have the obese participants in this grouping. These have tended, again, not surprisingly, to have had to change their occupation, have several symptoms, and poor physical functioning. Number 3, the one with the brain fog, male dominated, they're overweight rather than obese, but a third of these did actually feel recovered eventually. And then 4, no female sex dominance, but were overweight. So some of you may be surprised by that incidence of long COVID in our study. Remember, these were all hospitalized, and you may have seen last week this data from ONS on 50,000 patients with long COVID, and they were reporting much lower incidence, really down at 3 and 4% of participants. But there are some differences here. So these were a real mixture of those who were not hospitalized and those were hospitalized. The symptoms, there were 12 symptoms requested, and these were, again, not as broad as the one in our study. But again, they found some similarities, a higher instance of females, this middle-aged being dominant, the adults with pre-existing disease, and also those with a PCR test who had a higher viral load. So some differences in the data, but certainly if you were hospitalized, the picture is of a high incidence. And these are some of the sort of international data. So the first records came out of Italy, and it was a small study, only 143 at 2 months post-discharge, and they had 87% who were not fully recovered. Then a study from the UK, again, a smaller study, 191 with 74% at 3 months. One from France, 51%. Our own study of over 1,000 with a 70% not recovered. And then 2 studies coming out of China at 6 months and a year post-discharge, again showing even at a year, a half of the patients are not fully recovered. So as Pierre Mohammed said at the start, this is going to be with us for a while, I think. What about the community managed? So this is a study called TLC, which is being run out of Birmingham, and there's another large study, I think, out of UCL, looking at those that were not hospitalized. And this is the early stages. And so far, we've really only got data from the ONS and from the long COVID support data, but it's showing even in the non-hospitalized, probably about 14% not fully recovered. And again, dominated by what I would consider the young middle-aged group, female, high deprivation, and the presence of comorbidities. Okay, so I want to go in just in the last few minutes into some of the mechanistic side of things which might interest the attendees, hopefully. So this is data from the Sarcopenia group study. And there's myself at Birmingham. It's a large team, of course. The Nottingham group is led by Paul Greenhaven, Charlotte Bolton, and Neil Greening at Leicester. And what we're doing in this is we're trying to understand the fatigue after exercise and the poor physical function of the patients. We did work with the James Lind Alliance, and we found that trying to improve or get rid of this fatigue and poor physical function really was a research priority for the patients. We're trying to ask, well, is sarcopenia, loss of muscle mass, strength and function, is this the underlying cause? And to do this in this tier 3 study, where we've got 3 elements. We're going to look at autoantibodies directed against muscle. Is this one of the reasons we have myositis there? We're going to use MRI during exercise to look at organ compromise in a broad range of tissues. And then we're going to look at various obic levels analysis. So first of all, in our frailty assessment, so we've used the Freed frailty criteria, which many of you will be familiar with. So it has 5 criteria: a shrinking, so that's a loss of 10 pounds or more in the last year, feeling exhausted, low levels of physical activity, slowness when moving, and weakness. And what we found in our study, this is slightly more than the reported study, we're up at 1133 now. So 23% have no evidence of frailty in this grouping. To be classified as pre-frail, you have to have 1 or 2 Freed's criteria, and we've got 63%. So the majority are pre-frail in our study, and 14% were frail, so have more than 2 criteria. And what do our patients look like when we're looking at frailty? Well, I think this is the surprising thing. If you look at the age on admission to hospital, yes, we've got, there's an age link there in that the frail group is slightly older, but they're still what I would call relatively young to be classed as frail. No real change or effect of BMI there. The frail were, of course, in hospital for longer. What about comorbidities? When you look in this grouping, they're dominated by cardiovascular, ill health and respiratory. There is an increase across from non-frail through to frail, but yes, certainly at the highest level in the frail groupings. Comorbidities, yes, again, so the multimorbid, then high in the frail group. But when we look at the sort of the severity of disease, this is quite surprising. So yes, as you go through, we have 39% in the frail group required mechanical ventilation. But these guys wouldn't have been particularly frail beforehand, otherwise they would have not received that. So we think that certainly a large grouping of our patients here who are participants who are frail probably were not frail beforehand, may have been pre-frail. But we're going to have to go back to some of their perhaps GP records to assess if there's anything there perhaps on the e-frailty index that would indicate whether this frailty occurred before or after their COVID-19. What about sarcopenia? So this is a horrible diagram. So the data here on the left here are just showing that pre-frail, frail and non-frail again. But in our grouping, we just had 8% that were sarcopenic, so had loss of mass, muscle mass, physical function and strength. And of those, approximately half were frail and half were pre-frail. So it's certainly there as one of the explanations, but may not be a dominant one. So if we break down some of the categories, so these are some of the physical function tests, so the shuttle test, the sit to stand, the fatigue ratio, you can see these increasing with, so this loss of physical function as we go through to frailty. But when we looked at from the DEXA scans and the MRI data and also bioimpedance data, so we've got a mix of those data sets, they're not particularly losing muscle. But what they are losing is quality in their muscles. So hand grip strength divided by their lean mass is declining. So not particularly loss of muscle mass, but they've certainly got probably poorer quality of muscle. Okay, so quickly onto some of the data. So we were interested, this is data from Alex Richter based at Birmingham that we're collaborating with. And she was wondering whether the range of symptoms we see in COVID-19 might be due to the presence of autoantibodies. So she's looked in non-COVID acute ITU patients, COVID ITU, and then the convalescent. So these are the 3-month data. And you can see that certainly there's a reasonable number that have got 2, 3 or more autoantibodies, even in the convalescent stage of COVID-19. And when you look at what they are, when you look at the acute stage, what Alex has shown is really just a particular, so just no particular dominance of any one autoantibody. But when you look then at the, this is in the non-COVID, but when you look in the COVID, you see a very different pattern. So we see the ANA staining, a lot of this epidermal staining, this intracellular staining, the sort of cell cement type staining, and also a high level of skeletal muscle antibodies, which is, of course, has piqued our interest. And when you look then at the 3-month in the convalescent stage, we're then picking up a lot of cardiac antibodies. Again, we're still seeing this intercellular cement, as Alex calls it, but now we're also getting a high level of patients with smooth muscle as well as skeletal muscle. Those that were non-hospitalized, the cardiac is still persisting and the smooth muscle, but we haven't got the skeletal muscle so much in the community-based patients. And so what we're doing now is we're actually looking, we're taking 100 samples each from patients with and without sarcopenia and looking at the antibodies to really try and find out what are these antibodies directed to, because we've got almost 1 in 5 of our post-ITU patients have got these antibodies. So are they ones particularly associated with myositis? And then we'll try to relate these to evidence of muscle breakdown and myositis from the MRI scans and other markers of muscle damage. The other thing we're doing, and this is led by Charlotte Bolton and Paul Greenhalgh at Nottingham, is this study called Dynamo. And this is where we're looking at multi-organ damage, again, to try and understand the symptoms in the patients. And what they're able to do in Nottingham in their Sir Peter Mansfield Imaging Centre is to not only image the patients while they're static, but also they've got this ability to exercise them on this foot exercise here. So they can actually challenge the body, so an exercise challenge, to pick out then deficits that really would not be picked out if the patient was not being challenged in any way. And what they're finding is, an example here is looking at phosphocreatine recovery after exercise, which is an indicator of mitochondrial function. So you will know that phosphocreatine is this shuttle in the muscle that provides phosphate for ATP generation, and the rate at which this phosphocreatine recovers is an indicator of mitochondrial oxidative capacity, so the number of mitochondria and also how well they're functioning. And what they've shown already in the Dynamo study is when you compare a healthy volunteer with a post-COVID patient, then there's really a severe deficit here. So we don't know yet whether they've got less mitochondria in the muscle or whether their mitochondria are just functioning poorly. And that's what we'll be able to do through the muscle biopsies that we're taking in these patients as well. I hope I've given you a nice review of what's going on, and I'm quite happy to take questions now.
That's great. Thank you very much, Janet, for a comprehensive talk. Very interesting new data. Any questions from anybody? Please put your hand up. Maybe I can start off. Janet, you had some clusters, 4 clusters you defined on the basis of symptoms. Are you developing an algorithm that can be utilized to determine how you're going to end up in which particular cluster?
Exactly, that's so ongoing now. What we're going to do with when we take all of these data, particularly some of the serum biomarker data, is to try to, yes, see which patient, whether we've got biomarkers or whether it's some of their clinical data that are suggesting where they're going. Yes, that's exactly what we're aiming to do. And we're doing the same in the community study as well, so the non-hospitalized. So the TLC study is using machine learning to cluster their symptoms and again try and see what's driving the clustering. Okay,
great, thank you. Eddie.
Yeah, Janet, I had two questions, both related to vaccination. The first one is, does vaccination change the quality of long COVID? I'm sure it impacts the number of long COVID patients, but I wonder if it changes the profile that you see. And secondly, in those patients that you're looking at for long COVID, if you then vaccinate them, does that have an impact on their profile as well?
Gosh, partial answer to both questions, I'm afraid, Eddie. Vaccination, really, we haven't got enough data at the moment because, because that will come through. All we know so far, as you'll probably know, get much less severe symptoms at the time of the infection, the acute infection, but whether they get less long COVID, we just don't know yet. And if you and the second question, very pertinent, if you vaccinate, then does it help? Again, we just don't know. Some of data that I've got that Alex Richter's managed to get suggests that it may help with the level of the autoantibodies, may help to bring those down, but it's a little too early to tell. But those are certainly questions we're looking at. Yeah, great questions.
Thank you. So there's a question in the chat. Is there any evidence of muscle or immune senescence? That's from Mark Lazarus.
Oh, great. Yeah. Yes, certainly. Muscle, we don't know yet. So we've got just over 65 biopsies at the moment, and we will begin analysing them. Immune senescence, yes, we haven't published it yet. We're literally writing, we're in the final stages of that. But yeah, quite marked immune senescence. What we don't know yet is whether that precedes the patient, whether they had it beforehand and that makes them more susceptible. Our feeling is probably certainly a lot of them did have that beforehand. And why we're thinking that way is there's a nice paper came out from UK Biobank analysed data where they looked at the biological age of the UK Biobank participants, and those back when they first came in 2006 and 2007, they followed them, and the ones that were hospitalised with COVID-19 had a higher biological age. They were biologically older by about 10 to 14 years. So my suspicion is that these guys probably certainly had some degree of immune senescence beforehand.
Great. Can I ask you about international comparisons in terms of epidemiology? There's lots of things which appear in papers saying that it's much more common in the UK than it is elsewhere and so on. Do we have any good data on international comparisons?
Yeah, so one of those slides I showed, yes, actually, no, we're pretty equivalent, if you look at the data from Italy, France, the 6-month data from Wuhan, we're very similar in our levels, very similar. Okay,
and if you were to guess, I know it's the early stages, what do you think is the main target for long COVID? Is there just one target? Is it the mitochondria? Is it another organelle? Or what exactly is the target that is leading to the problems and so on?
Yeah, I don't think there is one, I think we're getting those clusters because there are different targets in the different patients. I think, clearly inflammation is going to be a big driver of a lot of the systems, the fatigue, but I think the autoantibodies are going to come in as well with some of the cardiovascular and the muscle symptoms. Yeah. Okay, great. Well, thank you very much, Annie. That was a really, really great talk.